Thank you all for being here today. Can everyone in the room hear okay? Yes, okay. And those on the phone can hear as well. So welcome everyone to the last CRISP Big Data Seminar of the year. If you haven't yet done so and you would like to be alerted to other educational opportunities through Accords and through CRISP in particular, don't forget to fill out the sign-in sheet up front. And if you haven't gotten an evaluation form, this is much better attendance than we anticipated, so get them while you still can. So thank you again for being here. My name is Bethany Kwan. I am the Accords Education Program Lead upstairs in Accords, and I am a D&I investigator and health services researcher here. And I want to say thank you to Dr. Elaine Morado and Dr. Deb Thomas for being here today to give this great talk. They're going to be presenting on methods for linking multiple data sources for implementation research, including geospatial data, which I find very exciting and is Deb's area of expertise. So I'm really excited to hear about that. Dr. Thomas is a professor and chair in the Department of Geography and Environmental Sciences at the downtown Denver campus. She also has a secondary appointment in environmental and occupational health in the Colorado School of Public Health. And she is our local expert on geographic information science and technology and has worked with a number of investigators here on campus to apply geospatial analyses, and she has students who also do that work. And so if you're interested in that area, look to her for that. And then also Elaine Morado, who I'm sure many of you know, is the interim dean and an associate dean for at the School of Public Health. She's also an investigator in Accords and is a leader within the CCTSI doing dissemination implementation science. She runs our I-Core training program, which I just want to give everyone give that program a shout out. Great program for learning about how to commercialize innovative research projects. So if you want to do that in the future, keep an eye out. They run it twice a year. And one other educational opportunity that I wanted to tell you all about before we get started, I'm going to ask Demetria McNeil. Do you want to come up and use the microphone so everyone can hear? To come talk about a workshop that we're doing in June.
Thanks, Bethany. For all of you all that are in attendance and for the colleagues that are not here that you think can benefit from the information, I strongly urge you to remind them for two things. One, there was a handout just as you come into the boardroom here, and I ask that you grab that. And the other, there's been an email that has gone out, and there will be a repeat email, and that is for the Dissemination and Implementation Science Conference that is going to be put on by the D&I core team here in Accords. It will feature present Elaine. Bethany will be on program. Demetria McNeil, who's a postdoc fellow with the D&I team. And it will also have premier investigators that we're going to be hosting, one being Enola Proctor, the other being Paul Estabrooks. We will also feature Russ Glasgow, for those of you that know him as well. It will be June 21st and 22nd. I highly encourage all of you to not only come, but please extend the invitation to your colleagues. It's going to be a great 2-day conference that is going to be extremely interactive, and also we will include experiential group learnings as well. So it will be a conference that you will not want to miss. If you have any questions, you can see me after the conference. Again, my name is Demetria McNeil, and I look forward to seeing all of you in June. Thank you.
Thank you, Demetria. So without any further ado, I want to turn this over to Elaine and Deb.
Good afternoon. Good afternoon. Good afternoon. This is interesting being like in a room like this. I normally not be. We don't have microphones downtown in classrooms, so just shout. Yeah. So I want to welcome you. Thanks so much for having us do this presentation. I hope you'll enjoy hearing about a really tremendous intellectual journey, and personal, actually, but an intellectual journey that Elaine and I have been on for about the past 5-6 years now. That all started in a focus group workshop where we ate lunch together and started talking about what one another does. And as creative intellectual minds will do, we started dreaming up what we might be able to do together which then has come to fruition in many parts throughout this much broader project, where we've interfused the geospatial piece at steps, not as a core component of what has unfolded with this project, but as a very important subcomponent. So really excited to share this journey with you and the evolution of our ideas as we move through this project. Did it just turn off, I think? See, mics don't like me.
There you go. I thought
There
you
you
were
go.
asleep. It's like rooms where the lights
Yeah,
go
I
off.
thought I was asleep. So I'm gonna turn it over to Elaine to give the background to the much broader project and the theoretical implications of the dissemination science and implementation science portions of this, which are not my expertise at all. It's the geospatial piece, and then you put those together and you'll see some pretty amazing stuff unfold.
Or
We think so,
Or we
anyway.
think so. We like we like what we do. So I know this is at the end of a year-long seminar focus around big data. And some of the topics that you've had have focused around what is the data elements, and some have been around the statistical inference and so forth. This is thinking about how we might pull these data together and repurpose it to help understand how interventions are disseminating, how they're being implemented, how might we get more out of this big data to help guide us in strategies. So we've organized it in a way of, as Deb was saying, as a story and a journey, a little bit as to the big picture, what we were trying to accomplish scientifically, our rationale, what were the data that we had available. We talk a little bit about how we actually went about the linkage, but not in depth. So there may be follow-up if people are really interested in, well, how-tos. We're happy to show that or answer that later. And then we try to make it come to life so it's not abstract, and use the case that we've been working on, or I've been working on for the last decade, which is with Missouri Medicaid in the area of mental health and psychotropic use. So I'm trained as an epidemiologist, a pharmacoepidemiologist, and so we work with these kind of big data, administrative data. We were trying to get more out of the data that we had available. And so we'll be talking about linkages with the administrative data that we've done with physician survey at a population level, other data sources, in this case, a physician market data, and then as Deb mentioned, geospatial, which is embedded in administrative claims data if you know to ask. And looking at the D&I application in two areas. One is looking at comparative effectiveness research question for a new long-acting antipsychotic, and the other one is implementation of diabetes screening, okay? So just to ground everyone, because I'm not sure everyone's background in here, what typically is the kind of data variables that you might find in electronic administrative health record kind of data? Usually there's a file that will tell you patient eligibility, some demographic data around that person, age, maybe race, ethnicity, et cetera. And then there's a linkage variable that's around the patient, and you can link it with the other medical and pharmacy claims data that might include diagnosis codes, procedure codes, dates of service, actual pharmacy drug information like the drug, days supply, and so forth. And so in pharmacoepi big data studies, this typically is the kind of data you're dealing with. You're using propensity matching, you're using other kinds of methods to adjust for confounding due to patient characteristics. And the best patient characteristics you have is what got coded as part of the claim itself. But in that data is also linkage IDs, not just with patient, but the patient to their record, not just their eligibility and demographic, but within that, you can also get access to where do they live. And depending on the clearance of data eligibility, you can get all the way down to their zip code of their residence. You can also, if you work with a provider, in this case it was Medicaid as our partner, you can get access to provider ID data that allows you to start to think about what other provider physician data can you acquire to bring in for a richer understanding. And so we always start in D&I with a framework, and the frameworks that we were trying to expand upon is, in this case, theory of reasoned action and planned behavior, all around beliefs, attitudes, perceptions, and how that relates to intention and then ultimate behavior. So if I'm trying to look at the implementation of a certain behavior, adopting a new drug, adopting a new metabolic screening routine. What is the attitudes? And perhaps this is where we should be focusing our D&I strategies, for example. But to do that, we need to understand attitudes, and surveys are a leading way to try to ascertain that. Small area of variation, many of you may have know of this background as well. A long line of literature dating back several decades looking at rates of healthcare utilization events, and we know there's been geographic variation, underutilization, overutilization, and many hypothesized causes of that. Again, to start to understand clinician preferences or differences in disease incidence or access to care, we need to be able to link our data through that geospatial to other data sources that might allow us to explore that. And so that's what we were motivated with. Also, we were motivated with how do we take the learning of the Dartmouth Atlas group, which some I know have worked with, and their big data maps where they map out the variation and so forth. And how do we start to leverage that and tie that in with the data that we're looking at to look at implementation and adoption of behaviors? So these are often cross-sectional studies. We look at a point in time. We were interested in also looking at sort of the evolution of this over time. You know, you have a patient in a place over time. And through the geospatial kinds of data or linkages, we're able to link it with other available national sources. So many of you all, I assume, are aware of the US Census data. You can get that down to specific tracts, as well as zip code, and scaling it up to larger units. HRSA has an area resource file that you can purchase that also has some basic census data, but starts to let you understand about local provider of care environment, like in a county level, how many hospitals are there, is there a shortage in primary care, things like that, that give you context around what is that availability or supply of health services that might lead to under or overuse. There's also market data. I don't know how many of you have used any of these sources. I used to work in private sector, and this would be the data sources you would go to see if your product was doing well in the marketplace. So you have Nielsen, you have IRI that look at UPC codes every time you go to your grocery store. Those sites, that is generating very big data that is sold to researchers to understand those purchase patterns, and then you can buy that as a researcher and link it with it. IMS is one that also sells it more in the healthcare area. We actually went with one that sells it to pharmaceutical companies, and that's market data that it pulls from different sources to say what is the prescriber specialty type, because that's something you really want to understand. In our case, antipsychotics, they're prescribed by psychiatrists, they're prescribed in family medicine, they're prescribed in emergency medicine, and yet the prescriber type is often not found in Medicaid and those kinds of data. And so we went to market data to help get that information in, blend it with what we had in the survey data so that we had a much more robust understanding of who is the prescriber that's making these decisions. And again, it was linkable because we had a relationship with Missouri Medicaid, our partner, and they allowed us to have access to the provider files. So, you know, if you want to go, anyone wants to talk about that, there's a long data use agreement process, but it does allow you that ability then to start pulling together more creatively different data sets. And so why does this matter for the dissemination and implementation? Well, you know, dissemination is all about the intent of spreading knowledge, and implementation is about promoting the adoption. And so it's not just a cohort of people in a particular place or state. We want to know, is there variation in dissemination uptake or knowledge understanding? Is there variation in implementation as it relates to a state, in our case, Missouri, or whatever the healthcare system is? Why? Because we cared about policy informing research for health system leaders, policy leaders. So if we say we're working with the state Department of Mental Health and they agree we want to have everyone screened for diabetes associated with these drugs, antipsychotics because of the risk, help me understand what intervention should I do where. Right now, a lot of it is just hypothesized and it's not targeted. It's just everyone gets the same thing. And we were at a point where we were really trying to better target the interventions given the limited resources that are available to many of healthcare systems. And so we hypothesized, physician data allowed us in a much more richer and granular way start to explore what are barriers to adoption. How do the attitudes and beliefs relate to the adoption of sort of new drug evidence? And could we start to think about segmentation analysis the way you do if you were a company that was marketing a product? You start to understand your customer and you segment and you tailor your interventions in marketing so that it appeals to them. And we wanted to understand at the very basic level, where were there differences between specialists and non-specialists, but were there attitudinal differences even within that group that we needed to tailor our messaging? We started with a conceptual framework as we think about the middle line here of a patient being treated all the way to the behavior that we were interested in, which is getting a diabetes testing. And we hypothesized that there might be different barriers of knowledge that might be better attuned to implementation strategies related to education. There might be different barriers related to persuading and training. There might be ones related to, in this case, mental and medical care coordination. Or it could be just everyone's bought into it, but our lives are busy and they needed reminders. So the only way we were going to get at kind of that information was by surveying, but it allowed us to link the survey data with the rich data we already had as other explanatory factors, the patient characteristics I mentioned, practice characteristics that we could get from other sources. And so this was the framework that was informing our analysis. We were also interested in geospatial. Again, think of it from the state partner's perspective. Should I do something in this, if you think of the state of Missouri, there's major cities, St. Louis, Kansas City. There's the Ozarks, which is their very rural area. And then there's other parts of the state as well. Should they do something different in mental health centers in St. Louis and Kansas than they are doing in, are the problems the same as in the Ozarks? And we hadn't really explored that at all. Otherwise you just look at the data as here's all the people who got on a certain drug in a certain time. We wanted to see the place, the setting in which they were, so that we could have a better understanding of the problem, where was the variation. We could start to think about key determinants that might be affecting implementation. And we were also interested in, at this time, was looking at best practices for comparative effectiveness research and how you might say confounding by geography might be influencing causal inference, and how do we best adjust for this and look at it. And where my interest in is not just looking at this retrospectively, but can these learnings inform us in real time so we could use these data more as a surveillance mechanism. Okay, so that's the rationale. That's what we were trying to accomplish in our journey. And Deb is right. I met Deb at a qualitative methods training, which actually was an Accord sponsored. If any of you go to the QRMF training, it was many years ago. Early, what is qualitative methods, and that's where we met. So you never know who you might meet in one of these Accords CRISP seminars, right? And strike up a collaboration. So, so what is our context? Just a couple of slides. I'm interested in adults with mental illness. They're at increased risk of developing diabetes, earlier death due to cardiovascular disease, by some standards up to 20, 25 years earlier death, and particularly socioeconomically disadvantaged. And at the time, a lot of data was emerging in the mid-2000s, a lot of undertreatment. Under-recognized that patients with mental illness had serious cardiovascular risk. Everyone was focused on suicide risk. At the same time, this is what brought me into it because I'm interested in drug use. You had antipsychotics that were increasing, not just use among schizophrenia, but bipolar disorder. It's now used as adjunctive treatment for major depression. And it had really evolved as being one of the top 10 best-selling drugs in the US when you looked at dollar sales. And so there was a lot of concern, issues around overprescribing and off-label use. So you have these sort of convergence of problems around also the fact, and this is some of the variation that you can see in the uptake of it, but related to the metabolic risk, this started to emerge. So you have people who need antipsychotics and the antipsychotics themselves increase the risk for diabetes, for cardiovascular disease. There was a series of class warnings that came out initially in the mid-2000s and then got solidified to class labeling by 2012. And now if you look at it, it's part of NCQA HEDIS indicators, a lot of the policy here in the state as well. Collaborators like Ben Miller are focused on this mental health, medical care integration. So again, is the setting available for good screening of diabetes in mental health environment? So it's very interesting from an implementation science problem because there's a lot of moving parts and context really matters. And we were very fortunate to be able to partner with one of the leading thinkers in Medicaid, Joe Parks from Missouri Medicaid. And so Missouri was generally a representative type of state when you compared it to US normative data around Medicaid profile and general health of their patients. And he was really interested in wanting to build collaborative partnerships with academics to get the best knowledge given the data that he had. So he was a willing partner that allowed us to work with his data and get a little bit extra linkage information so that we could pull in more sophisticated analysis. And a couple of years ago, Missouri and his efforts was recognized by the American Psychiatric Association for all their work that they've done in community-based programs. So it also provided a lot of change over time, which is always nice when you have an experiment, you see variation, and you want to understand that. And so it was a dynamic state as well. Early work showed that psychiatrists understood these drugs had risks. They agreed it was a problem. It was altering their prescribing. And our early work found that that didn't translate. So this was our base case. We just did it with typical claims data. We were able to look at a time series and look at the percent of patients on starting atypical antipsychotics as opposed to other patients in general who had diabetes. And we really found that there was no change in the likelihood of patients getting screened before or after all of these warnings. So that was discouraging, right? So this was a time where people were understanding that warnings weren't really changing much. But at the same time, we did find that they may not have adopted or implemented diabetes screening, but we saw that they unadopted use of certain drugs. So this one line that goes down is one particular drug, Zyprexa or olanzapine, that had the greatest risk of metabolic. And in that warning period, it dropped, and another one increased, aripiprazole or Abilify really increased. And so you can pick up some things by using base claims data, but we wanted to better understand, well, how come this change occurred around prescribing, but not the change about adding metabolic testing? Was it because people said, you know, I'm a psychiatrist, I don't do that, that's a primary care person's job? Is it a psychiatrist really trying to do it and just the patient doesn't follow through? Is it, you know, I'm managing the risk by changing my prescribing patterns, so I don't need to worry about the diabetes screening? None of these questions could really be answered, and each one might have a different implementation solution if we only knew what the problem was. And so that's what intrigued us. And we were starting, at this point is when I met with Deb, and we said, well, let's try and get something can we get anything out of the small area variation in geography? And at this time, all we had was county level data because we hadn't gone and asked for the zip code level data yet. So we had county, and we were working in 3 states. And you can see how the 3 states, this is glucose testing or diabetes screening. You can see how there was different patterns of variation in the states. So we're observing something that looks interesting, and that intrigued us. And so that was part of the reason why we put in the NIH application, so that we could get survey data and we could get more at the zip code level data. And in publishing that, we also got a nice letter to the editor asking about, you know, making sure that it was very clear, and we responded that the watch out in looking at geographic variation is that you can't just look at pretty pictures because variation is normal, right? We expect normal distribution, and so there's going to be some people at the high end and there's going to be some people at the low end. What we're interested in is it's statistically different, that these clusters we're observing is outside of what you would expect in the norm. And so that requires different statistical analyses And a common one is just looking at the intra-class correlation and making sure that the variation that you're observing geographically actually is relevant for a policymaker to do something, not just part of normal variation, random variation. Otherwise, it could be misleading. You could be identifying something to focus on and misallocating resources. The other piece that is important too is we can identify variation, but you should also look at the absolute rates. In this case, absolute rates, there were some sections that were getting up to 85% getting screened. So that's showing really good. But if everyone in our variation was below, 40%, that would say, yeah, we found variation and everyone is bad. Some are more bad than others. And so you have to also really look at what's the range of the variation before you make that interpretation. In this case, we found some areas that were doing very well and some that were doing very poorly. And so that led us to say there was enough variation to look at. And when we statistically tested it, we were able to say that, about 14% of the variation in total was explained between county variation that we didn't have information on. And that's what led us to the hypothesis around, could it be attitudinal? We did look in this study with the data that we had available, which was, I think, we did the best that we could with the area resource file, but this is only aggregated at a county level. And so at a county level, you're looking at, some socio-demographic characteristics of the population. You're able to look at poverty or how urbanicity. We were able to look at some things related to healthcare access. Is it an under primary care shortage area or a mental health shortage area? And we also able, in this case, to bring in adult prevalence of diabetes. You might say, well, maybe if this area, this county has a lot of diabetes, maybe screening rates are really good because they know it's a problem in general, not necessarily a problem for these specific patients. Anyway, that probably had the closest correlation. It had a marginal p-value there that is as well. So we were not satisfied. So while we knew that there was inter-county variation, we said, gee, are the variables that we had at our disposal to really understand it weren't really telling us very much when we included this in our adjusted analysis. And so again, more rationale why we needed more granular data. And in between, we had another study and we learned some insights of how to be more granular with Medicaid data. In this case, we were looking at the launch of a new long-acting injectable antipsychotic. Those that are familiar in antipsychotics, it's oral and there's a lot of problem with compliance over time. Compliance, particularly in those with most serious mental illness, leads to increased hospitalization, emergency department use. And so the hypothesis is if you had people on injectables once a month, it might reduce the hospitalization rate. And of course, from a company's perspective, that's now a branded product. And it's a value is that a value that justifies not doing generic drugs? And so we wanted to look at that. The other piece here, I think this was at a time with comparative effectiveness information. We have this data, the drug is newly launched. How do we know how it's doing in the field? Our state policymakers said, these long-acting things cost a lot more. Do I put them on formulary or not? What's my real world evidence? So he was pushing to say, can we get early comparative effectiveness data? And that's where you get into the tension of what's your sample size? Is there selection biases? Who are early adopters? And again, we wanted to see if that was clustering by geography. So we had some geospatial aims here in which we wanted to see, was there variation in the uptake of this drug, and explore whether or not there was any meaningful confounding if we were to take into account where the patients were located. And here we actually had patient zip code of residence that we could cluster into mental health service areas. This was important because, again, the state thought in terms of mental health service areas. This is how they deliver care. And so if we were going to kind of summarize that data in a way that's meaningful for them to say, oh, I might target this or that in this particular service area, it helped them understand. And we looked at hospitalization and emergency department visits. I put this here, this shows how we selected the patients, but mainly to bring up your attention to the bottom line. we only had in this time period about 350 new starts of the drug compared to 9,400 new starts. So it's a small market share, and so we wanted to, it could be what we're seeing very, what we might see in a comparison could be influenced by small rates in certain groups, and we wanted to be cautious and not interpreting the findings. So at the time, we followed PCORI's best practices and tried a number of different ways of adjustment, looking at the raw and the unadjusted rates. The first column is looking at hospitalization likelihood. The other one is emergency department visits. And you can see in some cases we achieved, or we found statistical significance. In a lot, though, it's sort of wavering around whether or not it's statistically significant, because anything over the one threshold would be not significant at the 0.05 level. And so we knew that we wanted to keep digging into, is this a true effect or not? Was it driven by sample size or maybe other things? And so that's also what motivated us into the uptake. And so we did at first some basic mapping. We wanted to look at the diffusion in the state. On the left, we're looking at the uptake of this new drug, paliperidone. And on the right is the uptake of the existing products, the orals. And right away you see the distribution of use is different. So right away it makes you wonder, why is paliperidone being used down? So that boot heel down in the state on the southeast side, that's a rural area. That's the Ozarks. And what we found was right across there is the Mississippi River. And a few years ago in the neighboring state in Tennessee, they had closed their mental health hospital. And where did a lot of those patients migrate? They migrated across the river into Missouri. And so what we found was that population is different. They were more likely to be in a kind of a hospitalized or semi-hospitalized group. And so that was different. Why the center of the state, we didn't know. But these were things that were made us curious, and we wanted to look further. And so we did further work with a colleague who was able to do more sophisticated analysis than we had done before, in which she was doing spatial empirical base smoothing techniques, as well as doing some different kinds of statistical calculations so that we could determine this level of autocorrelation in our mapping. And so we were able to get some more sophisticated ones where we're now looking at where were the, now on a smooth basis, where was the use rates. So again, you see similar patterns as to what I just showed. And now you start to see a little bit more of where there's what you might call hotspots in terms of its use. And I'm going to allow Deb to explain this to you all. Essentially, you're looking at which areas are really statistically popping up as being beyond what you would expect from normal variation alone. That's my layperson's explanation.
Yeah, so is it on? There it goes. So just a couple of little pieces I want to back up with. So firstly, linking the geographies is not necessarily an easy task. So you're joining by scale, level, where there is inherent error. You're also trying to link different kinds of locational data in every single kind of file. And I'll give you one simple example, and in the interest of time, I won't go into this a lot, but when we're dealing with the physician database and location, for example, that you'll see coming up, and the survey data, are we talking about their building address or their office address? And what if they're at multiple locations, right? So that's just one example where it becomes complex very quickly as to which address or which location you're ending up choosing in thinking about access to care in that particular instance. So data, this group is very familiar with that. The spatial piece of data is just as complex as all of the other elements that you're incorporating in. And so the previous map, now it's turned off again. I didn't like my voice.
I think it just keeps turning on and off.
I'm not holding it back. So then if we back up to the smoothed maps, what the Bayesian spatial smoothing is doing is it's not giving us any statistical relevance here. It's just looking at the neighbor and weighting by that neighbor to help visualize where you might be seeing clusters. So smoothing it, but not dissimilar from those initial maps that are allowing us to generate hypotheses, but not really say much statistically about that clustering or what's driving the clustering. So if we go to the next map then, what you see happening here, the Moran's eye is a global clustering spatial autocorrelation for all the data. And so it doesn't really say anything about the local characteristics. The Lisa that you see mapped here is local indicators of spatial correlation. And so that is statistical, and it is local to those areas. And so you see that boot area in the lower right, a little bit in both maps actually, really popping up as high prescribing oral or high usage oral and for the long acting. What's interesting, I think, and were you to zoom in, you see this a little bit, is your two, and I'm not there.
Here, I'll help this, you do that.
There we
It
go.
just keeps going
I know,
off. It
that's
cycles
what I-
off because the battery's low.
So the Kansas City and the St. Louis areas are really acting somewhat differently than your rural areas. And that's interesting. It's still not telling us what's driving that, right? Which is where we were really heading next. So is it patient characteristics? Is it community characteristics? Is it some combination of those? Is it something to do with variations in access? Is it physician characteristics? And with this complex database, a set of databases actually, we've been able to think about what some of those interactions are. Now, when we did the statistical analysis on this, before we go on, that's the hospitalization. So you see something kind of similar.
So if you've ever looked at confounding, you look at, is there variation of the exposure drug? Is there variation in the outcome that would say, do I think I have confounding that I need to worry about? Yeah.
And then same series.
Yeah.
In this particular analysis, when we did the statistical multivariate analysis, then the patient characteristics were driving these patterns much stronger than any of the geographic characteristics in this particular instance. Now, having said that, it did show that there was some linkage to geography. And certainly in the patterns, if you're thinking about it depends on your lens, right? So if you're thinking from a policy perspective, that might be something a little bit different than thinking about it from a pure, strictly epidemiological perspective or a surveillance perspective, right? And what some of those patterns are going to be taken to mean and how you might end up using them. The geographic variation piece, if you think back, we've all seen the epi triangle that has environment on one corner. Elaine had the little cup at the beginning in one of the very first slides that had place on it. Place matters, community matters, where we live matters. And if we're not taking that into consideration in our statistical analyses and our comparisons, as well as then in the translation to the policy piece, then we're probably missing 1/3 of what we're trying to explore, right? Place matters fundamentally, and we talk about that in different ways in different parts of public health, but it does matter. And geography, of course, that's where we start. So we like it very much. So that there was some evidence in this in the comparative effectiveness studies that we should be taking geography into consideration and adjusting for that, as well as some of the patient level characteristics or the physician characteristics.
Yeah.
So
So, I'd be curious, those that do observational comparative effectiveness studies, at least when you go to the pharmacoepidemiology conferences, it's all about propensity matching as it relates to the ICD-9 codes and CPT codes and patient-level codes. There's very little, if any, discussion that also talks about place. And so while this particular case didn't show it, I believe strongly that people should investigate whether or not that confounding is there before just assuming that everything is just being adjusted fine just based on utilization. So stay up here, and I'm just going to get to it. So why do we get that little detour in looking at antipsychotic diffusion? It was because that was teaching us new ways of thinking about the data. It was new. We could not have done this as well without that partnership with the state Medicaid. So Dr. Joe Parks was involved in all of this work. And so we would do a little and learn together, and then that would drive more hypotheses and what ifs, and that drove what questions that we wanted to have in the surveys. And so it led to this last round of slides here, which is looking at disseminate. We wanted to see now, we have place, and in place we have different settings, and we have community mental health settings, we have non-psychiatrists, primary care providers, et cetera, and they've been disseminated different risk messaging. And we were curious if the dose effect makes a difference on that. And so now we're turning to the ability with the survey data to try to get at around attitudes and that. Now, I didn't put in here all of the challenges of doing survey data collection. I know the Accords group is very familiar with that. But what we did is we had the provider identification file, and that provider file had addresses. And we were told by the state, this is a fantastic address rate, less than 2% wrong addresses. We send out all of our quality improvement drug utilization kinds of letters that way. We don't get anything in return. What we found out is that's not the case. We actually had, I think, up to 15% missing incorrect mailing. But because we could link it with market data that we had for those doctors, and that market data was actually more up to date because, think of it, they're selling it to companies who are doing doctor-specific mailing, right? And so having accurate mailing there is much more important to that purchaser than maybe the state who's just off sending their letters. And so there was more of an, I shouldn't make light of it, but there was more of an economic incentive for that private sector file owner to make sure that they were routinely updating. So we were able to merge in that data set, not just to get sort of market information, but also for the additional addresses to do the survey. Now, at the end of the day, I think, we had, I want to say well over 90%, 95%, we had accurate addresses. But then you have the challenge of, well, gee, why don't all the doctors do my survey for me, right? So we probably, the crude rate was around a 35% response rate, in which many said, I don't prescribe, I only prescribe once, so I'm not going to do it. But they at least responded. And so maybe the net effect was around 30% or 27%. Well, now you have sort of missing data, right? So I'm linking the survey data in, but it's not fully complete. And so what we ended up doing was going back to a primary analysis, which is just using the claims data because we had all of those variables for every one, and using the survey data as our secondary data where we had more enriched. Our original goal was that we would have had survey data much more generalizable, at the 60% or so. We had over 80% response rate among community mental health centers where a lot of these patients are seen. But once you went out to the general population, and we were trying to take a general, population health perspective. So those were interesting challenges. I'm just going to 2 slides here. But because we could link with the prescriber specialty, either through survey or this market data, we were able to, I think, get a very interesting graph. The top one is looking at the circles represent how many people are in that segment. So the top one is share of patients. Bigger blue circles means they're representing more of the patients who we're trying to target. Big red circles means it's a greater share of prescribers. And what do you see? You see very small community mental health centers, CMHC in the red. It's a very targeted group representing a disproportionate size of patients, a bigger blue circle. And that's why a lot of dissemination implementation efforts have gone to them, because they see a lot of those patients. But if you're taking a population health implementation view, where is most of the prescribers that you have to reach? Still a sizable blue circle, and that's this primary care, right? So the primary care, there's a lot of them. They're not seeing as many, and so their challenges are a little different. It's not as front of mind because they don't see these patients as often, patients getting antipsychotics. And then you have this other group, right, which is this fragmented, all others, unknowns, out of states, things like that. And they represent a smaller circle, but that smaller circle is still about 15% of the population. So if your goal is to get 100% of everyone, in this case, getting screened for diabetes, if you can't reach these others that are fragmented, you're never going to get to 100% because they're out there. The other thing we were able to do, and this is where the survey data helped us, because the primary attitudinal factors were the type of prescriber, setting, and in this case we were asking them, would you definitely, in this case definitely would screen, and it played out also into the screening information. The biggest predictor was their attitude that this was important for them. And so those within community mental health centers, the largest, those that agree that screening is a priority for my organization were more likely. Those that disagree with that would have a barrier. So we tested a whole lot of questions on our survey, and this was the one that was really the largest one. And you could say, well, gee, that was a lot of questioning and you only found one thing. But I flip it and say, this means the state is not going down a lot of rabbit holes, doing all sorts of D&I interventions that they've hypothesized, when in fact the largest lever that they had is to basically say this was important for the state, for Medicaid providers. And so our last slides, I'll let Deb finish, which is coming back to the same data, informed by what we did with that long-acting antipsychotic, and say, can we start to look at the heterogeneity of diabetes risk management? Couple that with what we know in terms of survey data, and see if we can get a richer understanding. And this is where the analysis is right now. We just have a couple slides here. We can answer any Q&A.
I might just do this instead. A little better, maybe. So first off, I would like to use this opportunity as a plug that when you're doing survey data, and if you think that there's something spatial going on, which if you're doing a statewide sample, presumably that's part of the case, that also mapping the response rates is quite useful. That's been useful to me since I was doing my PhD program, and seeing if there's any gaps in response rates in places where you're not getting them, or where you have over-representation. And we did do a bit of that. We haven't extended that to incorporate it into the analysis portion. That's a next step. So where we are right now, and Randy, if you could raise your hand, please, Madam. This is Randy Johnson, you may know her. She has a high interest, a PhD student in epidemiology, and a very big interest in spatial analysis, and has been through her master's and her PhD program doing work with us in various ways. So she has kind of taken up the rope, the slack, whatever piece we want to call it here, for the spatial and looking at the metabolic screening aspect, the next step. So we looked at prescribing patterns, we looked at emergency visits, hospitalization, and now the metabolic screening, and do those correlate and associate? So are you seeing the screening in the same places that you're seeing the prescribing, for example? And so this is just some initial work that we've started this spring, looking at exploratory data analysis of that glucose testing. And you have to flip your brain halves for this map, because this is no glucose testing now. So high does not mean high testing, high means high no testing. So we have a double negative going on.
So let me just add why. Because over time, things are getting implemented. And now the problem is not where is it not, or where is it, or we're trying to understand early adopters where it's happening. Now we're trying to understand the laggards where it's not happening. And so good news, but it's still, with this last 20% or so that are not testing, where are they?
Yes, exactly. So you end up with a double negative in thinking about it. And so if you want to think about it that way, using the term laggards, there's some interesting patterns here. And you see some rural areas in Missouri doing a very good job, which you've seen that all the way through, and perhaps that's their experience with prescribing and their high diabetes rates, etc. What's interesting is the St. Louis area, which is this area here, right? So we can do it right here for the people online. So that's the St. Louis area. You have some very highly clustered low metabolic screening going on in the St. Louis area. Now, I could be cynical and say, if you know anything about St. Louis, this is maybe not such a surprise, but wouldn't necessarily expect that in urban areas. And when we zoom in to the St. Louis area, you see even some patterns that don't align with some of the health equity or health disparity literature that we know. And so it isn't just the lower income minority neighborhoods that are experiencing the low metabolic testing. It's also some very high income zip codes. So neither one of which we want, right? So in the context of the health disparity literature, this has a lot to come to bear to say about this as well. And there you go. There's the zoomed in version of St. Louis, some hot and cold areas.
So what makes this really interesting from an implementation science and where we are is that also in St. Louis is WashU, Washington University in St. Louis, which is a big center of psychiatric research. And they've had a huge, their investigators have been in the lead nationally around the charge for metabolic screening. So here you are in St. Louis. Washington University has, they're part of, I think, 4 community mental health centers, early adopters in trying to think about behavior change and quality improvement. And so, but there's also huge resident training programs, and they're the ones that are going out in the field. So it's a very interesting dynamic in which one way they're really forward thinking. And in another, this is where we're starting to see some of the good areas relative, but also red areas, challenging areas. And so is it just they're not doing it, or is there something that's related to the patients not flowing through and actually getting the ultimate testing and so forth? So is it an ordering problem, or is it a follow-through problem? Is it both? But again, these kind of data allow you to have those discussions with state policymakers so that you can brainstorm with them. Because that's the other, I think, advantage of both the survey and both the geospatial, and then we'll just open it for comments, is it something that's relatable? Sometimes when you have just a lot of statistical models and you're showing relative risks or odds ratios for the lay policymaker, they glaze over. But when you actually have the questions that we're asking clinicians like yourself, it resonates. When you show maps and they have an understanding of how care is delivered in their state, it resonates. And we've used these also as a tool of engagement with our implementation partners, because ultimately we've chosen not to go that way personally, but ultimately we wanted to use this data to inform what would be the right intervention to design. This would be the preliminary data for that, and they would be part of understanding why we wanted to go forward. So, the point of this talk hopefully was maybe to spark in you some thinking about how you can be more creative in the use of large administrative electronic data as you're doing your analyses, and opportunities to link it with non-traditional other data sources. So thank you.
Yes, thank you. I was just going to say, yeah, just one final piece. And so as any good research agenda, you end up with more and more questions along the way and directions to go. And I think what's exciting is, as Elaine mentioned, the maps become a really nice platform for that, whether they're statistically embedded or more descriptive for a wide variety of audiences. And to end, I think working with Missouri Medicaid, that also gave us a great opportunity to do was talk about the interpretation of those maps.
Right.
And that
And the
works in
survey
the
data.
community as well, and all of the data, in fact. Yeah, thank you.
I know we ran, there's no clock. It's stuck at
It's
12.
12:20.
So we've been we probably went right to the minute.
Yes,
So
it is 12:59.
Yes.
So if you have big comments or questions and you'd like to stick around, you get about 10, 15 more minutes in the room. I'm not sure how long you can stay, but feel free to go off to your next thing or stay and ask some questions.